speaker, who is Dr. Sara Lewin. She's a gastroenterologist specializing in the care of patients with IBD as well as other disorders of the small intestine and nutritional deficiency. She is truly the epitome of UCSF's acronym, which is You Can Stay Forever, after completing her MD residency and GI fellowship at UCSF before joining our faculty in 2018. She's one of our beloved associate program directors and site director at Parnassus. And she does so much academic work, including research on improving inpatient care for patients with IBD and GI diseases, and also is the creator of our inpatient IBD order set, one of two UCSF faculty members who does the double balloon enteroscopy, and is also our point person for our AI-assisted video capsule assisted technology. And beyond, honestly, all of her professional achievements, Sarah's just so beloved amongst us fellows. And she has her unique tradition of remembering every fellow's Seacom song, which is individually chosen to commemorate each first-year fellow's successful colonoscopy intubation. So we are so lucky to count Dr. Lewin amongst one of our mentors and faculty, and super excited to hear her talk today on inpatient IBD management.
Well, thank you, Lakshmi, for that very, very kind introduction. Really happy to be here and meant to just kind of think through the management for hospitalized IBD patients. Often these are patients that will stay on our consult list a lot longer and linger a lot longer than some of our more acute GI consult questions. So it's something I think that we actually do have a little time to delve into in thinking about best practices. I have no disclosures relevant to this talk. And then in terms of learning objectives, just to be explicit, number one is to articulate the indications for hospitalization in IBD. Number two is to describe the initial or kind of day one management of hospitalized patients. And I say day one because even though these patients stay a long time, that the difference between operationalizing management on day one versus day two can have outsized impact on the course of the hospitalization. And then number three, identifying the complications of IBD hospitalizations and steps to prevent them. And number four, determine the best strategies to promote safe discharge. This would not be a talk about hospitalized care if we weren't talking about length of stay and getting patients out of the hospital. So I'll start with a case just to kind of illustrate how things can really change quickly for patients. So this is a true story. 18-year-old man with no real significant medical history, had some mild intermittent asthma, presenting to his local GI with 3 months of bloody diarrhea. His initial workup showed negative infectious stool studies, hemoglobin's 13, inflammatory markers are mildly, if not at all, elevated, and his fecal calprotectin is a little bit elevated, but not terribly so. But amazingly, right, that this is an example where a calprotectin is not correlative of how much inflammation there was. And this is what his index colonoscopy looked like, which is really consistent with more severe colitis, Mayo 3, you can see spontaneous bleeding, ulceration, loss of vascularity. And the pathology showed chronic active colitis with distortion of glandular architecture. And so a diagnosis of ulcerative colitis was made. I think it was at that point left-sided ulcerative colitis. He was started on budesonide and Lialda and Rawasa. This was done in the community. I think a lot of us would argue that with that initial presentation of severity endoscopically, we might recommend actually going straight to biologic therapy, but that's often hard for patients to kind of wrap their heads around with an initial diagnosis. And actually, this strategy did seem to work for him, though, initially at least, and stool frequency improved to about 2 bowel movements per day, but still had some blood in his stools. However, it was a short-lived reprieve, and then ends up going to the emergency room with at least six bloody bowel movements per day and significant abdominal pain. His vitals are not particularly remarkable. Hemoglobin's 9.8, albumin is 2.9, and now his inflammatory markers are maybe starting to creep up more so than they had at baseline. So you guys are my GI squad, and I'm not going to do anything cruel like call people out individually unless you guys prefer, and I will do that if no one answers. So this is for our first-year fellows attending the course. Does this patient need to come into the hospital? What do you think? And there's no right answer. This is a good, easy, low-hanging fruit one to take. All right, I'm gonna pick somebody. All right, you're gonna call my bluff? All right, and then I'm gonna just go with I think Melinda, you're my first year on my screen. So tell me what you think. Do you think this patient needs to come into the hospital?
I think this patient needs to be treated emergently, but I don't think they need to necessarily be hospitalized for that unless that expedites access to treatment.
Great. Excellent. So thinking about indications for hospitalization, severe disease, obviously signs of toxic megacolon, failure of outpatient medical therapy, and we don't have other things that we can, like you mentioned, expeditiously or emergently get them started on. Complications of the disease like VTE, we'll talk more about, complications related to medical therapy such as opportunistic infections, and then severe extraintestinal manifestations. So, based on this, like he's kind of on the border of severe disease, and that's why there was no right answer because, he's having 6 bowel movements a day, doesn't have, he's not like severely mounting a like systemic inflammatory response. So it's kind of on the, not severely anemic, so kind of on the borderline. But you could say, well, is he failing outpatient medical therapy? Is there severe disease? Kind of depends on what you describe that. So how would you define or what would you characterize as severe UC? So I can popcorn down the line, but I want to give people a chance to pipe in if they want to. Okay, then Erica, I'm calling on you next. Sorry, you're next on my screen.
I think it's like the number. Oh, sorry, we're in the same room. Like just the number of bowel movements or the frequency of bowel movements in a day. If you're having like a lot of bleeding such that your hemoglobin is particularly low, and if you have any like, as you said, opportunistic infections, other components of that.
Great. That's perfect. So what we often will use, and this is a really old criteria, but is kind of our tried and true, no pun intended, True Love and Witt's criteria for classification for severe UC, and really looking at the number of bowel movements per day, frequent amount of blood in the stool, whether there are signs of sort of systemic toxicity with temperature, heart rate, presence of anemia, and significantly elevated sedimentation rate. And so based on him, and again, this is why I was meant to be ambiguous, he was kind of on this border of 6 bowel movements per day, having frequent blood in his bowel movements, wasn't febrile, but did have some mild tachycardia, some anemia, elevated ESR. So we're getting kind of this moderate to severe flavor for him. And so when we think about kind of why patients with IBD are hospitalized, more specifically, when we think about ulcerative colitis, we think about there's this concept of severe colitis and fulminant colitis. So severe colitis kind of fits in with what I was mentioning in that sort of far right column for the True Love and Witts. I'm looking at those characteristics, but for this concept of fulminant colitis, which to be honest, I think is most often what we're dealing with when patients are in the hospital, I think otherwise patients are often, if they're having 6 bowel movements a day or 7 bowel movements per day, having, a little bit of systemic inflammation, they're kind of trying to ride it out at home. Whereas, people who are having bowel movements every hour, they're having fever, they're having significant abdominal pain, distension, that's really more consistent with fulminant colitis. And that's, definitely higher risk for colectomy, higher risk for toxic megacolon and other complications. And then Crohn's is much more like heterogeneous in terms of how it presents. But Crohn's, it's not as complicated as we might think. And I really think about these 3 buckets of similarly, you can have Crohn's colitis, just like you can have, ulcerative colitis that requires hospitalization and care. But then the other 2 kind of subcategories are what I think about as stricturing or obstructive presentation. So people with large and small bowel obstructions, whether it's related to inflammation that's causing that significant obstruction or fibrostenotic disease. And then the last bucket being penetrating complications. So whether that's perianal abscesses or intra-abdominal abscesses, and that kind of follows a different management and treatment algorithm as well. So I think with Crohn's, just trying to figure out which of these 3 buckets does it fall into, and that will help guide your your sort of treatment plan. So following this case, so based on True Love and Witt's criteria, he technically meets kind of on the border of severe UC. And so he ends up getting admitted to the medicine service. Lakshmi already alluded to this, but we have a whole order set based at UCSF Health that is a pre-populated order set that the admitting team can put in with our recommended admission labs, as well as daily labs that may be helpful in addition to, trending C-reactive protein and albumin, getting stool tests on admission, and then some other medication management things like VTE prophylaxis that I'll discuss in a little bit. So as I mentioned, day one is really where, we could say day zero is such an important part of setting the stage and making sure things get done for the patient so they can get timely care more and have a decreased length of stay, decreased risk of colectomy. So what are the rate limiting steps in his care that must be accomplished as soon as possible? All right, then I'm calling on you, Grace.
Is one of them ruling out infection?
Yes, it is. That is basically the main thing that we are wanting to do, because we want to check for C. diff. We want to because certainly that can be a mimicker of an IBD flare, especially if it's more of that colitis type of flare. And then we are wanting to look for latent infections like TB and hepatitis B, because we need these results back before we can consider doing utilizing rescue therapy or biologics. Because if someone has latent hepatitis B or latent TB, or they have inactive hepatitis B, that we need to know that as soon as possible to mitigate the risks of reactivating those infections. And then also getting a patient's weight, because some of our rescue therapies are weight-based, and I have actually seen that hold up the delivery of infliximab or rescue therapy because we did not have a weight on file. So this is all kind of setting the stage, these last three setting the stage for rescue therapy and not letting anything hold us back. Just one other practical thing. TB testing depends on your hospital practices, but often quantiferon itself is a send out test, so that does not come back soon enough compared to a PPD. And so our workflow at least UCSF Health is to actually do PPD placement as soon as possible, so that at the 48-hour mark, we have a negative result that we can then utilize to give the go-ahead for rescue therapy. So in this case, the C. diff returns negative. The PPD is placed on day one. And this is where I put this. Hepatitis B serologies are pending. Usually at UCSF Health, that takes about 24 to 36 hours to result. And then the fecal calprotectin now is greater than 2,000. So this is just to illustrate that the calprotectin can really be quite variable over time. I think almost in some ways this was like a little bit spurious given the severity, but now we're really seeing that the calprotectin is really shot up. So he started on IV methylprednisolone. And now, what dose of steroids would you recommend? And again, there's not like a one right answer. And I will call on Asase, since you're next on my screen, to tell me what dose you would think about.
I think is it 1 milligram per kg per day?
So it ends up being it actually ends up not being weight-based, but it's in that ballpark depending on the size. And so basically our guidelines is about 60 milligrams. So it ends up like essentially being in that range for 70 kilogram person that we would see around that dose. But they actually have done they have looked specifically if higher doses, like what about the 1 gram of solumedrol, type of thing. And is that helpful? And we see that there's no benefit at higher doses. And this ends up getting really codified in our ACG guidelines that we really don't recommend more than 60 milligrams. I've definitely had patients who have gotten higher doses, and I've even kind of had to make agreements with patients who are like, no, I know what I need. I always need 125 milligrams of methylprednisolone. That's what works for me. And so, I think that we know that the data doesn't support the escalating doses. And so I think it's really meant to sort of say, like, if they're not responding to this 60 milligram dose, the chances that a higher dose is going to work for them is really low. He also gets a flexible sigmoidoscopy, and this is an important part of our evaluation to look for CMV colitis, which can also be a mimicker of ulcerative colitis itself. You can see our beautiful high definition Pentax photos here, but you can see the description is similarly consistent with what it looked like before, which is severe erythema, loss of vascular pattern, and friability. And so I had already alluded to the Mayo endoscopic subscore, but this is often put up in the workrooms and things like that. And you can Google, you can do an internet search pretty quickly, but this is our sort of standard reporting that we'll use for ulcerative colitis. And so we typically are reporting on the most severe segment of the colon. And so in this case, the big difference between moderate and severe is the presence of ulceration, so larger ulcerations compared to erosions, and the presence of spontaneous bleeding. So that is kind of what helps guide us there. But this is something you don't necessarily have to commit to memory, but just important to know. It's kind of good practice to include anytime you're scoping someone with ulcerative colitis, including in the hospital. So this daily checklist, this is something that we had published a couple of years ago in IBD journal, and this was based out of a quality improvement initiative that I had started as a fellow. It was really, at least initially, sort of piloted by Ryan McConnell, one of our former fellows as well. And this is really just kind of thinking about what you're needing to work through every day, right? This is not just like, okay, do they have melena and what's their crit, but really kind of systematically going through how severe is their colitis, what based on their symptoms, what is their colitis activity index, which has to do, again, similarly to number of bowel movements, percent that's bloody. And there is a dot phrase that actually incorporates all of these factors so that you're able to kind of move through this checklist in a way that's better integrated into the EHR. But you can certainly use this paper or digital, checklist to go through, making sure that all your labs are processed, that you're following up on any stool tests that might still be pending, looking for abdominal imaging, and especially if there's concern for abdominal distension, looking for colonic dilatation in particular, whether there's been endoscopy that's completed, TB status, hepatitis B status, reviewing medications, and we'll talk a little bit more about this, VTE prophylaxis, not just has it been ordered, but the patient actually getting it, nutrition consultation for all patients, colorectal surgery, et cetera, et cetera, et cetera. So there's a whole long list that goes through here. And then also talking about what are we working towards in terms of discharge and what are some of our goals. So that's, I think can be helpful to just go through this. Oh yeah, and then sorry, for TPMT, it depends on practice, because I think that you can also check for TPMT especially if you're planning on doing combination therapy with azathioprine. It can be helpful to get that. That is part of the order set. I think everyone's practice is a little bit different in terms of offering combination therapy with methotrexate versus a thiopurine, or just not doing combination therapy. Additionally, that sort of historically the TPMT had been checked often when we were using cyclosporin and bridging to azathioprine, and that's basically we needed that ready to go when patients were leaving the hospital. Whereas you maybe have a little bit more time for TPMT to figure that out if you're not putting them on combination therapy right away. So it's a little less mission critical, but definitely it is part of the order set and something that you can consider. So then in terms of our sort of daily tasks, we'll, what we think about is really, as I mentioned, assessing the disease extent and severity. And so when I talked about the simple colitis disease activity index, thinking about these things about how many bowel movements a day, how many times at night, how much urgency, are you having accidents? Are you able to hold it for a couple of minutes? Do you have to go right away? Getting a sense about where they are on that. How much blood in the bowel movements and extraintestinal manifestations. And often what will happen, I don't know exactly what the mechanism is for this, but patients who are hospitalized with UC will often have like really bad nights, and then the daytime often can be a little bit better. And so it all depends on when you're capturing them during like a pre-rounding or rounding to see like if you're like, how are you feeling? They may be like, I feel terrible or I feel great. But by capturing this kind of score on a daily basis really helps to essentially provide an additional objective marker about how they are doing, because it's easy to like think about how you're just feeling in that moment and not really take the whole 24-hour picture into consideration. So someone might say, I feel great this morning, but they had 12 bowel movements overnight. They may, they may not be doing as well as they actually are reporting. And then for Crohn's disease, we often want to think again about is the behavior of the disease? Is it more of an enteritis picture? Do we see stricturing or obstruction? Are there penetrating complications? And then you can use the Harvey-Bradshaw index to sort of, again, guide your daily symptom assessment in terms of, how much abdominal pain, what the stool frequency is. These other rare things like extraintestinal manifestations or the presence of an abdominal mass. Daily task number 2 is just reviewing the diagnostic tests. And so, definitely want to be following their complete blood count, chemistry panels, looking at electrolytes and albumin, and a daily C-reactive protein. And then I think just generally doing a good nutrition screen, all the infectious tests, and like you had mentioned, Linda, TPMT can also consider as well. As far as our third daily task, there are, making sure that we are not doing additional harm to patients. And so avoiding opiates, anticholinergics, and antidiarrheals. And this is always so tricky about how to best manage pain for these patients, because we do know that opiates mask the symptoms that patients are having, can contribute to bowel dilation. And in the outpatient setting, we know that opiates are associated with, increased risk of mortality, just kind of like from all cause. So we do take this really seriously. For what it's worth, we have submitted a study looking specifically at high opiate use. And we, even though it was a small group from our single center, it doesn't seem like there was a wildly high signal for colectomy or readmission or things like that for high opiate use, but definitely will delay, it will extend length of stay, will delay the administration of biologic therapy. So there are sort of other negative externalities that we see with opiate use. And then for VTE prophylaxis, like I mentioned, has it been ordered? Has it been administered? And then I think this is another really important piece, is that patients will often have their VTE prophylaxis held because like, oh, they're getting an endoscopy. But if we really think about, the risk of the endoscopy, if we look at those ASGE guidelines, that VTE prophylaxis dosing, the risk of bleeding from that is so low from an endoscopic procedure that falls in that kind of like low risk intervention and low risk procedure. And so I really advocate for continuing the VTE prophylaxis. Maybe not every attending you work with would say that that's the right thing to do, but if you really do strictly go by ASG guidelines, it should be okay to continue VTE prophylaxis without interrupting it in anticipation of a procedure. As the last thing I just wanted to mention is, well, these patients are bleeding, right? They're having a lot of bleeding. Is it the kind of thing that we are causing harm and making them bleed more by putting them on VTE prophylaxis? And there was a nice hematology meta-analysis that really kind of looked at all the studies for patients getting VTE prophylaxis with IBD, and looked at sort of the ideas. The number needed to treat with VTE prophylaxis to prevent a VTE is 35, whereas the number needed to harm is 114. And since, bleeding, we can always give more blood, but in terms of, the risk of VTE and blood clots, that is a lot harder to reverse. I really, kind of think that it favors treating patients kind of continuously with VTE prophylaxis unless there's hemodynamically unstable bleeding. All right, so let's move on. So after getting started on IV Solu-Medrol, he has a few questions for you. So what can I eat? I will ask Vo what you think the patient can eat. What kind of diet order should they have?
Hmm. I would say probably try clear liquid diet and then advance as tolerated.
Mhm.
I don't see any contraindication for that.
Yeah. Do they need to be strict NPO on TPN or anything like that?
No, definitely not.
Yeah. Okay.
Yeah.
So it actually, you want to basically advance diet as tolerated. So I think it's reasonable to start with clears or low residue and just kind of try to ramp things up. Certainly you don't want people to have their eyes be bigger than their stomach, but iatrogenic malnutrition is so common. And so I think we want to just be careful about making these patients NPO indefinitely for a flex sig or, keeping them on clears for a week, because that's going to really contribute to their malnutrition. And so I think this is an area that we can definitely make improvements on. So whether they need to be on TPN, though, I think that often will come up, especially if people aren't eating that well. So certainly if they have a bowel obstruction and you're not able to get a feeding tube in, and it doesn't look like this is opening up anytime soon, they have short bowel, they have high output enteric fistulas, or now there's kind of increasing thought that doing preoperative nutritional optimization with a short course of TPN may be helpful. So particularly if someone with a small bowel obstruction is looking like they're heading towards surgery, sometimes the surgeons will recommend doing some kind of essentially preoperative nutritional tune-up. So this is an area that I think, getting more and more common as well. The next question, how long will I stay here? So average length of stay, just so that you know, at UCSF is a week, and that's why they sit on our service. And so this is my little picture of a rock garden. And so when I was a fellow, we used to talk about our IBD rock garden that we would tend to, and we would rake the sand a little bit every day. And so I think that, these patients do end up staying for a while. And I think helping the patients recognize they'll likely be there for a week is I think helpful for them to kind of get their head around it. The range, and other studies have looked, anywhere between, 4.5 days to 13 days, depending on the cohort. So these are prolonged stays as opposed to the sort of shorter in and out that we see with other GI conditions. And so I mentioned a little bit about managing pain. So it's really, this is like kind of, an obvious statement, but I think important to keep in mind, which is that pain management really is about getting the IBD under control, as opposed to masking it with medications. We talked a little bit already about why to avoid opiates. And then I think one other thing I didn't mention is about the predisposition to long-term opiate use. And so that was the other big finding that we had out of the manuscript that we just submitted, looking at opiate use. High opiate use in the hospital predisposes patients to getting discharge prescriptions, which can then, sort of compound long-term opiate use, which as I mentioned, is associated with increased mortality in the outpatient setting. So I'm a big advocate when these patients are here and you're having trouble managing them with the kind of PRN, tramadol, which is a partial opiate agonist that may be okay, and Tylenol, that's not cutting it. Getting pain management involved, because they can actually do things like ketamine drips and like all sorts of gabapentin, other alternative pain modalities, and that can allow you to avoid opiates. So that was the kind of pain management piece, but this is a really hard part and about managing these patients, is that they have a lot of symptoms and we don't have a lot of great tools to manage them. But again, I really do want to stress alternative pain management modalities. So what happens if I don't respond to IV steroids? So there's this clinical prediction rules. One's called the Ho index and one's called the Travis index. And the Ho index looks at these different components, whether they're, what the bowel frequency is at 72 hours of IV steroids, is there colonic dilation, is there hypoalbuminemia, and if they, after 72 hours, kind of meet this high risk category, or using the Travis index, they have this high risk of positive predictive value of colectomy, and they really do think should be included for rescue therapy. And so I've messaged this before, I've put this, mentioned this before, but after the 72 hours, we think about really assessing these patients at this point. And so in this case, the patient has really not made much progress. And so he plans to start infliximab. And so the next question is, what dose do we use? So I'll ask you, Linda, what you think. Should we use 10 mg per kg or 5 mg per kg? There's no right answer.
I guess I have a 50-50 shot, so I'm
Yeah.
gonna say maybe 5 mg per kg.
Yeah, so this is actually really interesting that because I think our practice often at UCSF Health is to just give a slug of 10 mg per kg, but there's older data basically that shows that in terms of the incidence of colectomy, that, there is a better, I guess, a lower risk of colectomy with that 10 mg per kg dose. But so that's often why we do that. But if you look at some of these other things, like in terms of like overall risk of total follow-up, colectomy in patient years, there's no significant difference. So I think that it's a little bit of a question about whether it really makes a difference. But our practice is to do 10 mg per kg. And so that's what he ended up getting. But he wants to know, how likely is it that he's going to respond to infliximab? And so just so you know that when these patients come into the hospital, their risk of 90-day colectomy is about 20 to 30%, even if they get multiple doses of infliximab in the hospital. So it's still not like a silver bullet for patients. They're still definitely at high risk for getting a colectomy. So in this case, after 3 days after his infliximab, he's still stuck in the mud. CRP's better, but he's still not feeling well. And so this question comes up of, should we give him another dose of infliximab? And although this is totally contradictory to one of my hospitalized UC patients that is getting a second dose of infliximab right now, that the Parnassus team's taking care of, that there is this nice meta-analysis that came out a few years ago looking at the use of accelerated dosing, not decreasing the colectomy rate. I think, sometimes we want to just sort of throw the kitchen sink at patients, especially if their albumin is very low, because infliximab is bound to albumin. And so patients with really low albumin may be just shedding the drug. And so giving them a little bit more may be helpful. So, but, it would be really nice if we could get some information and check his infliximab level to know, like, is the issue that he's not responding because he is just shedding the drug, or it's just not working. And so in this patient, we actually were able to check an infliximab level, which showed a robust level with no antibodies. So that kind of convinced us that it's not an infliximab problem. It's, that it's not getting into him. It's just not working. So we consult colorectal surgery. And he's really hesitant because he's like, I just, got this diagnosis 3 weeks ago, and now you're telling me I'm going to have a major abdominal surgery. I don't think so. Can you do anything else? Can you please, think about other treatments? And so the next sort of question is, what other, treatments do we have that we can consider for rescue therapy? And so I will move on to, I'm trying to think if I got everybody from UCSF. Who did I miss? You can call them out. Otherwise, I'll move to CPMC folks. So I will, I guess I will ask Bobby, if you are there, to tell me if there are any other things we could maybe use for rescue therapy.
I think one option would be cyclosporin.
Yeah, definitely. Perfect.
That's the one I can think of.
Yeah, well, that was the next slide. So this is something we actually don't use that much because it's like a very toxic, kind of toxic and hard to manage medication. But with cyclosporin, it is a rapidly acting calcineurin inhibitor. You have to be careful in patients with hypocholesterolemia because there's a risk of seizures. It can cause renal toxicity, so you need to monitor renal function closely. And it's given as a continuous weight-based infusion. And you're kind of targeting this concentration, titrating it up and down. And the idea is it's a bridge to oral cyclosporin, which is then kind of thought to transition to a maintenance therapy. It's been described using cyclosporin as a bridge to a thiopurine, like we mentioned before, or vedolizumab. So these are, so this is one of our kind of tried and true, and actually was the main thing we had before infliximab came on the scene. But this question now is coming up a lot now that we have so many more biologic agents. Can we use, a different biologic agent? Could we use cyclosporin now that we have used infliximab? And they actually showed that there was no difference in colectomy-free survival if someone had failed one of these therapies. If you did it sequentially, it didn't end up showing that it benefited patients, and there was a much higher risk of serious adverse events. So we kind of do not recommend doing back-to-back cyclosporin and infliximab. But this kind of comes to another question about JAK inhibitors, which is our newest kid on the block. So there is a lot of interest now for use of JAK inhibition for rescue therapy. And Octave was the main clinical trial for tofacitinib, which is a non-selective JAK inhibitor, that showed it works within 3 days, and that it was actually an effective use, effectively was able to treat acute severe ulcerative colitis. We had published a small case series as well about this, and showed that we were able to get everyone to be colectomy free. And also that, sequential use of high-dose tofacitinib after infliximab was not associated with adverse events in this study out of Australia. And so there was this new proposal that we should be thinking about for these patients is that, they fail steroids, we give them a TNF, then we can give them, tofacitinib, you can kind of move through things. Or even more importantly, patients who are already have been exposed to TNFs, maybe they can actually get tofacitinib or other JAK inhibitors, which I'll mention in a moment. I think we're really excited. I think the tide has really turned towards upadacitinib, which is a selective JAK inhibitor. And so there's just been some early publications about using upadacitinib for rescue therapy. And this is, again, from this Australian group that looked at, in these 6 patients, what was happening to patients who were put on upadacitinib. And you can see pretty quickly that Mayo, clinical Mayo score, calprotectin, C-reactive protein, falls pretty quickly. And so this is something that can, I think, definitely turn patients around, so that if they're starting at, a significantly high, inflammatory burden, that they're able to have things fall pretty quickly. Within about a week or 2, you really start to see things moving in that direction. So after he begs and says, please let me try something else before surgery, we come to an informed consent discussion and agree to off-label use of upadacitinib after infliximab failure. 3 days after he's on 45 milligrams of upadacitinib, he has a marked improvement in his symptoms. His CRP decreases. So now the next to last question, I believe, is how do we know that he's gonna be ready for discharge? And so is there anybody who have I missed in our first year class so far? Oh, Gloria, I haven't seen you yet. Sorry, I didn't see you before. You're not off the hook. How do we know that this patient's ready for discharge?
So I guess kind of like how we were assessing the daily symptoms, we want to see his number of stools decreasing. We want to see the fact that his colitis is like signs that his colitis is resolving overall.
Yeah, great. So this is often what I'll tell patients that we're working towards, right? Because especially it's a long hospital stay. Minimal rectal bleeding, so less than a quarter bowel movements are bloody, ability to have good PO, good pain control, resolution of sepsis physiology, and the manageable bowel movement frequency, like you mentioned. So all of that, essentially wanting to see that simple colitis activity index score resolving. If they're having obstructive symptoms, that's resolving, that they're able to eat. And then, of course, if they have, an infection, sort of like an intra-abdominal abscess as well, they're not septic still, they have adequate pain control, and a good sort of antibiotic regimen in place. So that's like all the theory, right? But then the logistics about how we get people set up for a discharge. And so you need to make sure they've got good follow-up, especially if they've been started on rescue therapy. They need to continue that as an outpatient. They need to plan for a steroid taper, et cetera. So getting them set up, either if they've not established, if it's a new diagnosis or they're out of care, or getting them set up for follow-up with their established provider. Insurance authorization is a big piece of things. And so we want to make sure that they're not going to have too much of a lapse in terms of getting their IBD advanced therapy. Is a little bit less of an issue for the small molecules because, if you have a lapse in a small molecule, you're not at risk for antibody formation in the same way that you are for something like infliximab, where, if you have a delay, that increases your chances that you will develop antibodies and then will never be able to use that medication again. If they have any infectious complications like an intra-abdominal abscess, making sure follow-up imaging is set up. And then I think this is something that I'm really excited about. It's something I've been thinking about since I was a fellow, which is what do we need to have these patients sit in the hospital while they're on a dose of oral steroids? Because often what we'll do is we'll have them turn around, they're on IV steroids every day, and then all of a sudden they, we say, okay, you look like you're ready to go. Let's spend one more day in the hospital, have you take a dose of oral steroids, make sure that you fly. But this was data from our UCSF center looking at the rate of failure of the steroid transition. And that means either being readmitted within 30 days or needing to go from PO steroids back to IV steroids. And you can see that out of the total 159 hospitalizations, only 11 patients had a transition failure. So that means that these 150 patients did not need to stay in the hospital necessarily just to be watched. And I think this also demonstrates that we have a good gestalt about who these patients are that are likely to fail, because these are the patients that we ended up keeping in the hospital on oral steroids for more than 24 hours. Whereas these patients here, who we were discharged either with no oral prednisone in the hospital or were discharged within 24 hours of receiving their first oral steroid dose. And they all did, as you can see, incredibly well. So overall, I think we, have a good gestalt about who these patients are that need to be monitored. This study was not powered to really look at specific risk factors for transition failure, just because the number here is so small. But I think the big take home is that this is something from like our practice that we should be pushing towards to try to get patients home sooner out of the hospital, decrease their risk of hospital-based complications and improve length of stay. So I'm really excited about this. This is submitted and under review right now. A couple of other notes I wanted to just mention in terms of Crohn's hospitalizations, that's not like in the sort of UC playbook. So if someone has stricture Crohn's disease, we would expect an inflammatory stricture to resolve with corticosteroids in about 72 hours. You can use rescue therapy. It hasn't been as robustly studied in this setting, but certainly can be used in a similar fashion. And then if there's no response to steroids or rescue therapy, then surgical resection may be needed. And these are patients that may really benefit from preoperative nutritional tune-up, as well as sort of just thinking about co-managing with colorectal surgery and hospital medicine as you would sort of a standard small bowel obstruction. And then for penetrating Crohn's disease, thinking about, of course, antibiotics, drainage, whether that's with IR or surgical intervention. And then, of course, if there's no improvement with these sort of drainage and antibiotics, that surgery may be required, although often the surgeons like things to kind of cool off before they would do surgery, unless it's really, they're essentially patients not able to leave the hospital. It's just really uncontrolled. And these are patients that often are not on IV steroids because they have active infection. We're not giving them rescue therapy because they have active infection. And then these patients typically require a fair amount of follow-up in terms of IR tube checks and follow-up imaging and things like that. So just before I kind of wrap up, I wanted to save a little bit of time for questions and apologize for the whirlwind, just wanted to make sure we did the most of our time. There are a couple of other things that I'm really excited about in terms of future directions and ways we can improve the quality of care. So we've done a pilot study here at UCSF, which I named the Mosaic Protocol, our management of severe ulcerative colitis with ambulatory intravenous corticosteroids. And the idea is that for anybody who's taking care of these patients, they kind of just sit in the hospital to get a dose of IV steroids. So there's not a lot of other high-level hospital care that's happening for a majority of these patients. So we were trying to pilot to see, could we safely treat these patients as outpatients with kind of back-to-back daily IV steroid doses? They otherwise can be at home, eat what they want to eat. They can work or, be with their families, things like that, avoid infectious complications being in the hospital. This really kind of came out in the era of like patients not wanting to be in the hospital during the height of COVID. And so we are also in the process of that submitted as well, looking at whether or preparing that for submission to kind of describe our findings, which showed that the majority of patients were able to be successfully treated in an outpatient setting, and that they had similar satisfaction with their care and was, likely cost effective because they were not sitting in the hospital for a week. Another frontier I had mentioned already is how to better do pain control. Is there kind of like the equivalent of a ERS pathway for treating pain in these patients that with non-opiate agents? So that's another area I think that definitely could be well studied. And then lastly, this is something that has taken up a lot of interest in the colorectal surgery world, which is that when patients are getting bowel resections or colectomies, they're going home on usually like 4 weeks of VTE prophylaxis, just because they're post-operative, but also IBD patients who've had a flare are at significant higher risk of VTE. And so although we are really advocating for doing VTE prophylaxis in the hospital, should we be sending patients home on, a low dose of apixaban, for the few weeks after their hospitalization to really decrease that risk further? And because these events are so rare, it would require essentially their national sample or a very complex coordinated multi-center study to answer this question. So I want to just thank you all for your participation, and thank you to